cancer prevention, teenage pregnancy, as well as HIV, AIDS, and alcohol and tobacco use, among so many others. We are privileged and happy that we have Dr.
School. He's an avid reader and he's had a list of books that are his favorites, and I will go over some of them. One of them is Tractatus Logico Philosophicus by Ludwig Wittgenstein, and he also loves the work of Karl Popper, The Logic of Scientific Discovery, and also as a man of science, he loves Charles Darwin's book on the origin of species. Sapiens, A Brief History of Humankind by Yuval Noah Harari, and 21 Lessons for the 21st Century by the same author, Yuval Noah Harari. So we are very pleased to have Dr. Anthony Jenin Yeboah. If you can give us a wave.
Thank you very much. Thank you for a kind introduction.
You're welcome. One of our panelists that we have here today is no other person than Dr. Raymond Ahem. He's joining us from the UK. He graduated from the University of Ghana Medical School in 1999. He had his postgraduate training in the UK. He trained in psychiatry, and at the moment he's qualified general practitioner, as well as he has qualification in family medicine. His main interest is in lifestyle medicine. I'd want us to welcome Dr. Raymond Ahem to the program.
All right. Thank you very much for your kind words.
You're welcome. You're welcome.
All right. The next person I will introduce is Dr. Owusu Dome. So Dr. Owusu Dome is a board-certified internal medicine physician, works with the Zion Hospitalist Group here in Phoenix, Arizona, the United States. He is currently in his 30 years of practice as an internist, a whole wealth of experience. Dr. Owusu Dome did his medical school in the Kwame Nkrumah University of Science and Technology, and he did his residency in internal medicine at the New York Medical College. And currently, his area of focus is into complex wound and hyperbaric medicine. He's so loved by his patients, and he has such a tender heart for medicine, and we would love to hear from him today as far as his role in COVID-19 management is concerned. So, Dr. Owusu, welcome on board.
Thank you so much, and sorry for being tired. I had some trouble with the link. Anyway, thank you. Yeah,
we are happy that you joined us eventually. You're welcome. Yeah, one of our panelists is Dr. Capilo. Dr. Capilo is a physician and a writer from Southern California. He received his MD at the University of California, San Diego, and completed his dual residency in internal medicine and pediatrics at LAC USC Medical Center in Los Angeles. He's currently working as an assistant professor at Loma Linda University Medical Center, where he frequently works as a hospitalist on the COVID isolation wards. Additional areas of his interest include international health and tropical medicine. I'm really happy we have somebody that has been working on isolation wards, so he'll be able to share his wealth of experience. You're welcome, Dr. Capilo.
Very good to be here. Happy to be with you guys.
Right. So we have with us also Dr. Nana Jomo. He is also an attending emergency physician with Team Health and Emergency Center, Phoenix, Arizona. So Dr. Nana Jomo had his education from Northeastern University, where he earned a BSc in biology, and then he further on had his degree in medicine from Western University of Health Sciences in California, where he had his DO degree. And then he went for his residency in emergency medicine at the Midwestern University in Chicago. And currently he's an attending physician with Dignity, also Abrazo Health Systems in Phoenix, Arizona. He spends most of his time with his family, and also he volunteers with medical mission work in Africa. So we are glad to have Dr. Jomo with us today.
I'm glad to be here.
You're welcome. The last, but definitely not the least, is Dr. Steven Blackson. He's currently the clinical care coordinator for Upper West Regional Hospital. He's a member of the case management team for COVID-19. That's the Upper West region of Ghana. He's an emergency physician. He graduated from University of Ghana Medical School with MB, CHB, and BSc in Medical Sciences. He has membership in emergency medicine at the Konfanotri Teaching Hospital in 2017 and has since practiced as an emergency physician at the Upper West Regional Hospital. He's a member of the Upper West Regional Rapid Response Team and is the leader of the regional case management for the COVID-19. His special interests are in trauma and improving emergency care in the rural areas. We are blessed this evening to have with us Dr. Steven Blackson. If you can just say hello to us, we would appreciate that.
Thanks very much for having me. Thank you.
You're welcome.
And just a fun fact, Steve is one of my mates in back in medical school. So we were in medical school together for close to 7.5 years. So yeah, wow. Nice to see you again, Steve.
Awesome. Awesome.
All right. Great. So we will begin. But first, I think, though we've talked about various roles, we will just want to hear a little more briefly about our panelists and their specific roles in the various hospitals they work in, or various facilities they work in. So we will just have a quick round, like a minute each, for our panelists to just tell us like their specific roles as far as COVID-19 management is concerned. And if we can have Dr. Susan Montgomery go first.
Yes, I am not a direct provider, but I actually involved in a lot of programs that try to address COVID-19 consequences when it comes to mental health and behavioral health. And I'm a researcher that is trying to support people in their own resilience and support physicians in their important work as they're trying to help people. We know that the underlying issues are significant. I'm also a researcher on structural issues and why people get sick to begin with. We know it's not even, we know it is uneven, and that their playing field is not the same for everyone, which is why we see the infections pattern that we see. Thank you.
Thank you. Dr. Jenny Yeboah?
Okay, so I was with the quarantine program when Ghana had their first cases of COVID-19, and then when a batch of returnees were quarantined. Some were coming from Europe, some were coming from America, and then Australia. So we had to quarantine them. So I was part of the doctors in charge of the quarantine program. And then afterwards, when we had community spread, I was part of the isolation program for national isolation center since then, where we isolated those with mild and moderate, those who are asymptomatic, and then manage accordingly. So that's what I have been, that's how far I've been involved with the COVID-19 management, yes, mainly in Greater Accra region.
Thank you. Dr. Ahem?
All right, so I work in the UK. Generally, COVID-19, as we know, is a community illness. So it's changed the way we practice. I work in family medicine. In the UK, we say general practice, as you know. So we have a surgery patient population of 13,000. So within the area, would then have to change our consultation methods. All of a sudden, we've moved to a total triage system where everything is done by telephone consultation, and we invite you to come in, and you can only come in when we've invited you to come into the practice that way. And then following that, I'm the lead GP in this practice. So it's about organizing the COVID-19 protocols, and we've gone into social distancing, segmenting patients into, and we're all vulnerable, but there are more vulnerable people and extremely vulnerable people. So we had to segment our patients into these groups and then arrange their normal care during these periods. And also for those who do develop the illness, because 80% have a generally quite insignificant illness, about 15% might have other comorbidities, which we do manage in the community. And then about another 5% gets into the hospital, but it's mostly done by phone. And then if you do have the COVID symptoms, we have a respiratory hub, which is generally catering for COVID patients. So all those patients are sent to a hot clinic where you're seen in the respiratory hub. Otherwise, we just social distancing, dividing the patients, giving the appropriate care, and making sure that the community is safe, and still managing the ongoing care of patients as COVID goes on.
Thank you. Thank you very much. Dr. Osudome?
Yeah, so as an internist here, my role had been, admitting patients with, unfortunately, with COVID. When they come to the emergency room, I work with the ED physicians to assess the patient, and then I admit them to my service to the floor. We had I work from various different hospitals, and depending on where I would be, there would be separate COVID floors, and in some of the other places, we just kept the COVID patients to their room and isolated them there. So when we were at our peak, sometimes you go to the floor and you have about 15 COVID patients on your list. So then you call in your infectious diseases physician, then you make decisions on who is going to get what treatment and who is going to get what particular treatment, who is going to need oxygen, go through all the all the protocols, and then some of them I also followed through the ICU. Some of them I was consulted for their complex wounds when they had been admitted to the ICU, and I've seen a few in the nursing homes as well. So my experience with them has it extends from the emergency room through the regular COVID floors to the ICU and through the nursing homes. I've seen a few at the wound care center as well.
Okay, thank you. Dr. Capilo?
Yeah, so when the COVID pandemic first begun to spun out of control in about March 2020, there were discussions at the hospital I work at about starting a separate COVID isolation ward. And I was called in my first day of my shift at the end of March to be that COVID-19 hospitalist. So with little training and little understanding as to how it was going to work, I signed on. And in the initial month or two, working as a hospitalist, which for the layperson is just a general medicine doctor in the hospital, I would have to communicate to patients what COVID was itself. I would have to dispel a lot of sensationalism about the disease. I would literally be rounding on them every morning as the White House briefing on COVID was occurring on the TV. So I would have to kind of dispel a lot of myths and constructs about the disease. At the same time, I would also have to communicate the risks with them, and I'd have to communicate the unknown, including treatments such as remdesivir, dexamethasone, convalescent plasma, none of which we knew about initially in the first few months. Since then, it's gotten a lot easier, and we've developed a kind of a checklist management algorithm for patients on the wards. But from the beginning, it was a process of communicating the unknown. And I think that was probably the best way of summarizing being a hospitalist for these patients.
Yeah. Thank you very much. Thank you. I think we'll go to Dr. Jomo for his role and specific role so far with COVID management.
Thank you again. So as an emergency medicine physician, usually I'm the first physician point of contact to admission to the hospital. And so my role initially is initial evaluation, and any resuscitation effort is needed at that time. And then recommendation whether to admit or for patient to go home is usually done by me on my shift. And like the previous doctor was saying, sometimes you have to dispel some rumors about this COVID-19, who should be admitted and who shouldn't be admitted. Unfortunately, during the early pandemics, with everything that was going on TV, even people who were sick of other diseases, like they have severe abdominal pain where they have like almost appendicitis about to burst, they stayed at home thinking that when they came to the hospital, the COVID-19 was there to meet them. So that was a tough issue. So dealing with people suspected of COVID-19 and other disease process, it seemed to me like at a certain point, more attention was being given to a COVID-19 patient than actually suspected COVID-19 patient than other disease entities. So in my emergency room, usually a COVID-19 suspect patient may take up about 2 to 3 nurses, and therefore the treatment or management of the other patients were kind of not delayed, but things were in a slow motion. So actually, so that's where we are now. I'm glad things are dying up and things are beginning to return to semi-normal, and people that are really sick of other diseases are finally turning up in the ER. Thank you.
Thank you very much. And we have Dr. Steve Blackson, Emmanuel Steve Blackson, to tell us his experience, specific experience with managing COVID patients.
All right. So I play a dual role with regard to the COVID-19 pandemic. So I'm the head of the COVID-19 unit in our hospital. That's Upper West Regional Hospital. So over there, what we basically do is I provide leadership, and I'm also the one in charge of managing those patients that we suspect or have been diagnosed. So we ensure that the pre-triaging is set up, and then the appropriate infection prevention control measures and restriction of our OPD so that spatial distancing is enhanced. And then the other members of the team as well, with the lab technicians and all that, we all come together so that once the patient has been admitted, the appropriate care will be given. Because our region is much challenged with regards to doctors, I also double as the one who sees the critical cases, those patients who needs to be intubated and put on a ventilator and all that. So I'm the one in charge of the ICU as well. At the regional level, it's more or less like a monitoring and supervisory role. So we ensure that all the other treatment centers in the region, they have the appropriate training and knowledge and the logistics that's needed to manage these cases. And at times when we identify gaps in those less deprived districts, we provide them with support. We also ensure that appropriate transports are made for those people that need to be referred for one reason or the other. So basically, that's what I do. Thanks.
Thank you very much.
Hello.
Thank you very much for that brief introduction about your roles. So we will go in. I think Dr. Ahem, get ready to answer this very first question. Europe became a hotspot after China. The world was thrown in shock when thousands were dying in Italy. As we speak now, we have over 3.8 million cases in Europe, with the top 5 countries being Russia, Spain, United Kingdom, France, and Italy. And there's been over 211,000 deaths. And the 5 countries reporting deaths, unfortunately, your United Kingdom is leading the chart in terms of deaths, and followed by Italy, France, Spain, and then Russia. So, Dr. Ahem, what was the European experience in managing the pandemic at the initial stages, and how has it changed as we speak now?
Right. So, like we all said, COVID-19 is a totally new disease. It's gotten several names: novel coronavirus, then COVID-19, SARS-CoV-2. So nobody knew what we were really doing in the beginning. I think when it left China, it came to Europe first, and Italy was the country that suffered the brunt of most of it in the beginning. As COVID-19 is transpired, it tends to be more critical for elderly patients. So countries with more elderly patients seem to have gotten the brunt of it more seriously. Those that went into lockdown much earlier tended to do much better, like Germany, because when it started, our Prime Minister thought that, well, let us go for the herd immunity. So let's allow enough people with the COVID we're getting in the community. That way, the illness would get enough people immune to it, and that would mean it would go away quicker. But very quickly, we realized this wasn't that kind of disease, and then we went into lockdown in UK. So before lockdown, it had already infiltrated into the country. And I think a similar thing happened in Italy. And they quickly took people from China, and without actually quarantining them, they then allowed them into the community. So once they repatriated people into the community, it starts in a small community with more elderly people, and then they tend to actually be more affected. Because in Italy, for instance, most people who died were more than 60 years. And all the people who died, about 99%, had at least one comorbid disease. So comorbidity and elderly population tended to suffer more. Eventually, when the colleges and the institutions came out with the models that, well, we need to actually social isolate, that's when we then went into the lockdown, and then it started, obviously, it's a national program, so it's always led from the national broadcast. So we kind of stratified the patients into, we're all vulnerable, but then there are people who are vulnerable and those who are extremely vulnerable. So extremely vulnerable people would be those who would otherwise get flu jabs. So anybody with a cancer, with a severe diabetes, COPD. Somehow hypertension did not get into that criteria. So when we went to lockdown, these people had to go into what's called social isolation. They actually would go into isolation where you have nobody at all coming to visit you. If you need food and that kind of supplies, it's all given to you. And if you need medication, it's brought to your front door. And it's kind of brings some kind of mental stress. I had a patient who said he was so depressed during this time when he couldn't see anybody. So because of, I think, the amount of elderly people, and then those countries which did not lock down much early, they had the brunt of it. I think generally that's what I would say. Now going forward, we've learned a lot of things, but now that we've opened up, we've had a second surge happening in various areas. But we've moved into a total triage system where everything is done by either telephone consultation, video consultation, or online consultation. And then unless you're invited in to primary care, that's when you come in. if you're invited into primary care, the consultation goes on and they think you're high risk, you're then sent into the right area. So actually, if you need a test, there's a national number that you call, and then you're given a test, you go there for the test. And there are areas you can drive in, but you actually have to be invited in to have the test. So that way, we're beginning to control the symptoms. Another thing is the way different countries recorded it. In UK, if you ever have COVID-19 and you even had cancer and you're going to die anyway, most people were recording it as COVID-19, whereas some countries wouldn't record it. So it's been a lot of mixture about when we say COVID-19. It was not really standardized, the counting. So that way, and then countries with a lower old age population did much better. So I think in general now we've standardized it, we know what we're doing, and it's even across the whole board.
Okay, thank you very much.
Okay, awesome. Thank you very much, Dr. Raymond. Our next question will be for Dr. Owusu-Domeh, because it's basically related to how the pandemic was handled in the US. On Thursday, February 27th, it was claimed that the outbreak would be temporary, that it was going to disappear, that one day, like a miracle, it was going to disappear. Our president reiterated that America was prepared to deal with this pandemic. Dr. Owusu-Domeh, I want to find out, you have been at the forefront. In your opinion, do you think the American hospitals were prepared, adequately prepared for this pandemic? If your answer is no, what kind of preparation do you think should have been carried out?
Okay, yeah, without, I know Nat knows my political views and my views about some of these things. So without sounding too political and all that, I think almost everybody agrees, except those who are probably, for political reasons, don't have to admit it. We were woefully, fully prepared. When we started hearing about the disease in China, for some reason we thought with the huge oceans separating us and all that, we'll probably be a little safer here. We knew it would come because of the all the travel that goes on and all that. But for some reason we didn't do much, in terms of preparation, in terms of even in sharing information, in terms of handling people who are coming in from other places, in terms of people who were even diagnosed on the how do they call them? Those who go on the ocean. Yeah, we knew some of them actually had the disease on board those vessels, and they were coming in, but we had no clue what to do with them. So, when it started in Washington State, in a nursing home, by the time they knew, it had affected so many vulnerable people, and many of those, unfortunately, were lost. For my state here, I think our first patient, it was a student who came from China, somewhere early in February. And so I'm sure she was counted among the first 15 or so cases that the president was talking about. They isolated her in her apartment. There was secrecy around it. Even people in the same building didn't know who the person was and how to protect themselves from from that person. So it went on. Then firefighters started getting calls to come and see patients who were having respiratory symptoms, fever and all that. And then they went in without knowing how to protect themselves and even what they were dealing with. So many of our firefighters initially caught the virus here in Arizona. Then when they started coming to the hospital, we had no PPEs, that phrase that has become so common now. We were told, and the confusion was incredible. You would be told maybe you can just go in with maybe some cloth on your math or something like that, you were told at a point you didn't even need N95, maybe just a surgical mask would do, or maybe a surgical mask and a shield, and there was so much confusion. The information that was coming down was changing by the minute, so everybody got confused. My first patient, I believe I saw in early March. I went in and saw the patient. I had this tiny mask. I don't even know if it was fitting well. I didn't have a shield and all that. She was a COVID suspect, and after the end of, at the end of the day, we got a report that she had turned up positive. So you can imagine, I had gone in to see the patient very inadequately prepared, and that was the story for many of our patients. And even when we knew the patients had the COVID, we knew we had to see them, but we were also being told that it's safe to go in even without N95 and all. But of course, the story changed. So over time, I think we started putting infection control people and all these people in charge. So we started streamlining, and it became a lot clearer. And over time, we started getting the N95s and the gowns and the facial shields and all that. So it became a lot safer. But we had a lot of trouble, and then we had to go through the chloroquine and the Zithromax issues and all that. Sometimes you're pushing the infection doctor to, place your patients on these medications because you heard you heard on the radio, you heard on the TV that has been promoted as being very effective. And then the ID person may have a different idea, conflicts and all that until that issue was settled. Then the remdesivir came in, and then the plasma and all that. And you had to go through all these protocols. We had to keep changing from who will benefit from the remdesivir, and the level of oxygen requirement, and for instance, kept changing. So that was a difficult one. Then when the patients had stayed there for a week or two ready to go home, at that time, if you practice in the US, you know who could go home with oxygen and who couldn't go home with oxygen. Until that time, it was only people with established lung diseases like COPD and those with pulmonary fibrosis and all. Those were the only people who the insurance companies would pay to have oxygen with them to go home. But we also found out that the COVID people, even after treatment and making improvement, they were still making saturation of 88 when they start walking. They were making 85 when they started walking, and of course we couldn't keep them in the hospital even if their tests were still positive. The one of my harrowing experience was when I had to discharge a Native American woman to go back to the reservation. Her fever was gone, her oxygen requirement had gone down a little bit, but she was still positive. And I was sending her back to the reservation to mingle with a lot of people. There's no way she could isolate herself or even practice safe social distance or even good hand washing on the reservation. So that was a very harrowing experience. We've come a long way, and I think with the understanding of how masks help doctors and nurses and stopping the transmission on the outside, things have improved a lot. Many of our nurses caught the virus because of all these confusions about masks and what you can wear and what you cannot wear, and people were even punished for bringing in their own N95s and all that because there wasn't uniformity. But thank God, many of them have recovered, and we move on. My state now, maybe a month ago, we were just always in the news as the hotspot and all that. But then they instituted all these mask wearing things and all that, and suddenly. When last week I went to the floor and I didn't see a single COVID-19 patient. So we've come a long way. But I think we could have done better if we were prepared better than we were. Anyway, I think I'll stop here.
Thank you very much, Dr. Usu. Thank you so much. Dr. Jumo, I want you to briefly tell us how has the emergency protocols in triaging and managing suspected COVID cases evolved through this period, through this pandemic period? How has it evolved?
All right, thanks for the opportunity again. How has it evolved? Well, it has evolved in so many ways. And like I said, as usually at the emergency room, that's the first point of contact to the hospital. And you never, like we say in our field, you never know what walks in. You know, when you are oncologist, you know whoever comes to your clinic has a cancer. When you have an infectious disease, you know whoever comes to your clinic has infection to handle. Unfortunately, in the ER, we have everything in the pot, so you don't know who walks in. So the way it has changed the emergency medicine during the hot time was usually, you know, anybody that comes in through the triage, you know, is walked through temperature check and then he's taken to a room. And sometimes you will hear like, oh, somebody needs help immediately, and we have to rush outside of the building to start, you know, evaluation and resuscitation effort. But with this pandemic, it became to a point where even when you hear there's an emergency, first and foremost, you have to prepare. You have to be safe first. So then it may take you 2 to 3 minutes to don all your safety equipment and everything to go outside of the emergency room setting to help with the resuscitation effort if they need oxygen or something like that. Unlike previously, once you hear that, you just grab your stethoscope and you are asking, where is this, and you go there. So that's the main thing that has changed. And then when they do come to the ER, so far they are suspected COVID, their restriction within the ER is limited. You know, if they need some images, the radiology department has to come with the portable and do it there. But usually, if it wasn't COVID that we are suspecting, they could go to the radiology department, have their X-rays where they can have T-view and they can have more info with that. So basically, that's how it has changed. And it came to a point everybody is suspected, you know, COVID until proven otherwise. And yes, when you are not one-on-one with a COVID patient, you can't be wearing masks and all those PPE equipment throughout the ER for the next 12 hours. Yeah, so that's what has changed. And so with as soon as the more information became known, then we created a little isolation site within the ER, whereby, you know, once it's suspected, then we move it straight to the, you know, to the room where precautions are taken and everything else. So that's one thing. And the decision, and initially the decision of who to go home and who to stay was, you know, an issue because we're dealing with, so far as you can maintain your oxygenation level 90 or more, and you are not like having trouble, you are not, you know, working hard to breathe. Usually they could go home, but educating the patient that going home is the best option sometimes it's very difficult, you know. They look at the disease, it's like, okay, I have it and I'm going to die. And the irony is that people that you suspect they need to be the hospital, because of everything that was going on, they thought, no, if I stay here, I will die because that's what I see on TV. So I'll better go home. So even so that with this, because of this, your patient care time was being elongated because not only are you doing the medical management, now you are doing the convincing, the education, trying to go back and forth. I need to call my daughter to talk to her if it's okay. I have to call this patient to talk to. Okay, so you are being distracted from other patients that you need to, you know, to admit and take care of because you have a patient who has to make a decision. Clinically, you think the patient needs to be admitted, but they don't want to. So that's one of the main things that has changed, especially in terms of the emergency room. And before, initially, like in the emergency room physician, we deal with a lot of intubation. When you get to the point where you have to tell them that this is the tube you need to go to your throat, some of them thought like once you tube them and that would be the end of it. So again, it had to be education, convincing, and, you know, for them to agree that that's, you know, the way to go. And with our intubation previously, initially some of the doctors were getting exposed because we didn't have the right protection. Once you have the tube ready to open the mouth and insert the tube, we didn't have any protection except for the facial. And even that, there's still opening around it that when the aerosol is all over the place, anybody at all can get it. But during the later stages, some physicians develop a nice, box that you can just put over the patient, so that's only the patient head that is in the box, and you can go around it without exposing yourself very much. So there has been a lot of innovation and invention that has helped in the practice of emergency medicine, and so far the initial resuscitation. Thank you.
Thank you so much, Dr. Jumo. Thank you. Dr. Nate, I'll hand over to you.
Yeah, thank you so much. So in February, when the disease was brewing its head, Africa became a topical issue. I think it was Pliny the Elder who once said that out of Africa always something new. There were a lot of thoughts that the nature of Africa, the poverty, the housing situation was going to make COVID-19 a catastrophe. As of today, Africa has 1.292,113 cases, and the 5 cases that are leading are South Africa with 636,000, Egypt, Morocco, Ethiopia, and Nigeria. The 5 countries reporting these have the deaths as South Africa, 14,000 people out of the almost 600,000 people dying, followed by Egypt, Algeria, Morocco, and Nigeria. So, Dr. Jenin Yeboah, I will ask you this. Can you tell us about the experience in triaging COVID patients initially and how this has evolved?
Okay, so with the isolation center, we were mainly dealing with the asymptomatic and the mild cases. And we were also expecting the other members of the team in the community to also triage and make sure that the moderate and the severe cases will rather move to the treatment centers instead of coming to the isolation center. But if we get cases like that, we had our own checklist where immediately the patient comes in, we check the vital signs, and then find out the various symptoms, and then decide whether the patient needs to be accepted into the isolation center or not. Because the main mandate of the National Isolation Center we had was, yes, to triage, to receive cases, and then to review them, to manage them, and then to test them, and then discharge. When that's with the previous protocol where we were using 2 consecutive negatives, and then we will discharge accordingly. But with the new protocol, which currently Ghana is doing 14 days in isolation, then you just discharge. So at the point of receiving the patient, we look at the comorbidities the patient is coming in with. Is the patient coming in with hypertension, diabetes, HIV, sickle cell? Does the patient have asthma, COPD? We have to engage the patient at that level before we accept the patient. And whilst the patient is with us, we review the patient every day, checking the vitals, ensuring that if there are any new symptoms, we have to manage them accordingly. Or if the patient tends to develop any complications of the comorbidities, diabetic emergencies, hypertensive emergencies, we also manage them accordingly, or we will move them to the treatment, the treatment center. There were cases where we had patients with bipolar disorder, schizophrenia. So they were all part of the management of the patients in the isolation center. So that is what has been since we started the isolation center. And the treatment option we were working with was a cocktail of azithromycin, vitamin C, and then zinc. As time went on, we also added hydroxychloroquine. Currently, what has mainly changed is the treatment regimen based on the new standard treatment guideline, but the 14 days in isolation, because previously, because we were doing 2 consecutive negatives before the patient is discharged, some patients were spending longer time in the isolation center because we were getting patients who test negative isolation center. But with this current protocol of the 14 days in the isolation center being asymptomatic, then they actually spend at least a minimum of 2 weeks in the isolation center and they are gone. So that's what has really changed with respect to the management in the isolation center. But the triaging hasn't changed much because we find ourselves at a point where we are really dealing with the mild and the asymptomatic cases, because we wanted to move the positive cases from the community and then make sure they've recovered before they were sent back into the communities. So that is where we find ourselves with respect to the National Isolation Center, with respect to the triaging and the management. One key thing we're also doing was also the psychotherapy with patients who tend to get anxiety disorders whilst they are with us. Another thing was we also collaborated with companies. So, for example, you can get a positive person who is coming from a company. So we go back to the company, speak with the managers over there, help them to design their environment to actually reduce infection. And then we also test them. Those who are positive will be brought to the isolation center and will be managed. So that it was actually a whole long chain of a complete management with respect to the National Isolation Center.
Thank you. Thank you very much, Dr. Jenny Obra. Yeah, so Dr. Blanson, a lot of the media has spotlighted Ghana as a success story. As we speak, Ghana has had over 26 million, Ghana has had over 44,000 cases, and there has been 43,000 recoveries with 283 deaths. And I think the active cases are in the 1,400s. So it's been touted as a success story. And we want to know from you, Dr. Blankson, what do you think is the story behind this? And also, if there are multiple factors, can you tell us what these are responsible for this particular success story?
So thank you very much. So Ghana, we recorded our first case on the 12th of March 2020, after it has been declared as a pandemic by WHO. The main things that have helped us as a nation is that we had an agenda as a country, and it's centered on 5 key areas. Regards to, taking out the COVID-19. So the first one was to stop or limit the importation of the virus. And then the second one has to do with the fact that we contain the virus. The third one was, adequate care to those people that are confirmed. And we also had to put measures in place to limit the social and economic impact of the virus on the population. And the last one was how to deepen and expand our local capacity as a country. So the first one, with the limitation and preventing the importation of the virus, it was noticed that less than almost like the first 8 or so cases that we had, all of them were imported cases. So a decision was taken that if that's the case, then it appears that closing our borders was going to really help. So we did that. We feel that maybe if we had done it earlier, it would have even been better. But I think that one helped because it was noticed that I think the first 2 cases that we saw, they were able to trace all the contacts and they were able to, get all of them quarantined. Those people who tested positive, they isolated them and then they gave them treatment. So when it reached that point, all was decision at that time to sit where are containing the virus that come to the hospital. All clinicians were trained. I was part of the national team that were trained. So all the regions, we met at one place and they gave us adequate training on what we should do, what we should expect and everything. So it was kind of like all of us were having one message. Whatever that is being done in one region in Ghana, when you go to any other place, it's the same thing. And so that also really helped. And still on that, we hammered on the preventive measures. So the face mask, hand washing, social distancing, cough etiquette, and all that. Then when it comes to the adequate, the treatment of those people who were already confirmed, fortunately, during this period, we had some, the health system was having some form of renaissance. They had built some big hospitals with adequate resources that were yet to be opened. So this pandemic met us at that point. So we expanded our healthcare delivery by opening some of these facilities, and they really helped very well. And they were able to give us an option. So it wasn't like that much pressure that was going to be on the already existing facilities. Kind of, we had other places that we could reserve them solely for, COVID-19 cases. The government also did well by providing us enough logistics and then so drugs, personal protective equipment, and all that. So all these things came in place and they really helped. Then the other one too, it has to do with the economic and the social implication. We all know that every epidemic or pandemic has more than one dimension. So it has the health implication, the social or economic implication as well. So the government did well. I think during the lockdown period, they made an attempt to feed those people that because of the nature of their work, most people in Ghana who work are not in the formal sector. So some of these people, because of the lockdown, they cannot go out and work and all that. And if it's like that, then they may find it difficult complying with some of the preventive measures. So those things were done to, as it were, bring the impacts down a bit. And the private firms, private organizations, and institutions also really helped. There was a COVID fund that was set up, and they all came into play. So it wasn't like it was only the Ghana government that was bearing the brunt of it. Because all of them came in, we were able to also support a lot. My hospital in particular, we had a lot of donations that is outside the Ghana Health Sector, the mainstream organization that we fall under, and all those ones helped. Then with the capacity building, what was done was that the government identified certain local factories that could help in making face masks, making hand sanitizers, face shields, and all that. So what it meant was, instead of money, because of the pandemic, we're able to notice that we can do some of these things ourselves. And these things really help. But for me, key among them has to do with teamwork, especially the interplay between the Ghana Health side and then the president and the fact that they passed the law, you have to mandatorily wear a face mask and the ban on social gatherings and all that. These are the political dimensions that we as healthcare workers, we know how to deal with some of these things. But if they don't come in to help us in this regard, then there is no way we would have been able to get to where we are, what was going on. And the briefings helped in that what we all complied and we did it. At the point when they were even drafting the policy guidelines and all that, they invited our views. And so we were able to do some of these things. Then thereafter, another important thing is that the main testing site, they developed the pooling system. And so that also enhanced the turnover of the results as the numbers started surging, and we had a little bit of problem with the delays in sample. Getting our results. When we send the sample. So I think it was an interplay of all these things that helped. That notwithstanding, we still have some few challenges. some isolated areas in the country still face have some problems with logistics and getting their results. But on the whole, if you look at it entirely, I think the success has to do with some of these, key areas that are noted. Thank you.
Yeah, thank you so much for that extensive discussion on this. I'll let Brother Kelson continue with the next round of questions.
Yeah, thank you very much, Dr. Nate. This next question goes to Dr. Susan, and I'm quite interested because as a public health practitioner myself, it's an area that really interests me. I want to know from you, Dr. Susan, what do you think are some of the critical medical and social determinants of health that have created and sustained the pre-existing COVID-19 health disparities, which have put some racial groups at a higher risk of COVID-19 mortality?
Thank you for the question. And actually, it's interesting because I love the way you put the panel together. Because if we were to simply look at it at the face, with lesser resources, Africa should have been doing the poorest.
Exactly.
But they did the best.
Exactly.
So let me just leave that where it is and that it's it. Africa with the least resources did the best. And I want to come back to that because the theory of social determinants of health, I think, is a very important one, but it is actually very limited to the Western, it is more applicable to the Western context. In the Western context, due to our extreme differences in wealth, we have such grave differences between those who have and those who do not. So with the social determinants of health, those who, even though we have a medical system that is in theory the best and could perform at the highest level with others in the world, we are not offering those services to everyone. I am German, so I can speak from the German perspective as well as from the American perspective. When you grow up and you have access to healthcare, you don't think about healthcare, you go get regular care. Social determinants of health says from the beginning, there are systematically groups that are kept from getting access to not only proper healthcare prevention, also education and engagement. And on top of it all, when you overlay racism or structural inequalities that either consciously or subconsciously are perpetuated by the system, you make it worse. I think this COVID epidemic has laid bare the faults in our system. It's been like an earthquake for the Americans. One of the richest countries in the world by far has outperformed everyone else with the worst performance. We have incredible infrastructure with healthcare. In theory, I would say our public health infrastructure could be better and it should be supported. And if anything would happen, I think this COVID epidemic has pointed to how to support it. But I think we need to look to the countries who've done it successfully. And by the way, I'm aging myself, but I went to school 30 years ago. And we learned what? When we have an epidemic, we do 5 things. We identify, so we test. Then we follow up and trace. And then we isolate, which is exactly what our colleagues from Africa describe, having a centralized system. Then we educate the public about what to do, washing your hands, keeping social distance, wearing a mask. These are very simple and relatively inexpensive things. So if you put all of this together and it's centralized and it's actually planned and implemented with a wonderful teamwork, our colleague says, with very little resources, this epidemic in the US, the pandemic in the US, could have been what happened in Africa, what happened in Europe and Germany, where they still had some troubles, but they had a similar approach. So I really think that social determinants of health are significant because they keep people from prevention, from understanding, from care. But in the end, for COVID, I believe a logical, science-based, centralized approach, like the one that has been done successfully in Ghana, is the reason why we are doing so poorly. Now, Should we step back and look at the exposed inequalities? Absolutely. You know, I'm a big advocate thereof. But what really troubles me and excites me at the same time, how we can do relatively simple things, keep things under control, and help those if we do it equally and we do it organized. But unfortunately, our political discussion that was so anti-social determinants of health and so political against it actually infiltrated science and has kept us from a successful response. And in tragedy has left us with a country that is divided. So even though if we now implemented what Ghana did, what other countries in Africa did, what Germany did, we would have a lot of trouble implementing it. But social determinants of health, this pandemic has absolutely laid bare the reasons and the system of inequality in how we experience health in this country. Those who have good health, generally speaking, or if they are sick, they get good care. And those who have not are put at risk because they're the ones who have to work. Remember, our government required those at poorest health, with the poorest health care, they required them to work as essential workers. They had no health insurance, but they sent them out as essential workers. They were required to work, had no health insurance, no social net system, and no response. They were like the early doctors that were sent in there with a little cloth mask initially in the United States to deal with patients that were ill with a disease we didn't even understand.
Thank you so much, Dr. Susan. This is my area of interest, and we are going to definitely come back to you. Dr. Owusu-Dome, I want to find out, in your practice, have you identified any trends of those who die and those who survive from this disease? Have you identified any certain trend of those who die or those who survive?
This is what is happening, or what was happening in my neighborhood. It's a predominantly white community, but we also have a lot of Hispanics and a few blacks. We don't have too many blacks in Arizona here, but there's so most of the patients that came in that I saw were from the Spanish background, Mexican, South American, Central American, people like that. Many of them were born here. Many of them also migrated. Some of them are first generation. What was happening is, if you understand their culture, they live multi-generational. You enter one family, one house, and you have many. You have children, you have moms, you have grandparents, sometimes even great-grandparents, and they all live within the same confine. And they are very hardworking people. And so even when all these things are happening, and many of them were still classified as essential workers because they go and do the cleaning, they have to go and serve the food, they have to go and work at the grocery stores and all that. So one would bring it home, and then they come in the store. You talk to one person, anybody in your house has tested for, this person, that person, this one got it first. So it was many people in the same family getting it at the same time because of the nature of the culture and all that. So, and unfortunately, many of them also have diabetes, they have asthma, they have hypertension. And if you realize, one thing that came out to be very, very effective in dealing with very sick COVID-19 patients is what we call proning. When you ask them to lay on their belly and all that to give the lungs some chance to respond, it turned out many of these obese people couldn't even lay on people who had weight couldn't even lay on their bellies to prone. So that became a big issue for many of our patients. We had some, Caucasians and other races coming in. but the majority of my patients whose outcomes were worse and had to go to the ICU were of the Hispanic, should I say race or whatever? Yeah, so there were. I saw a few African Americans that came in. Some of them had to be sent to the ICU on life support for a long time. I mean, when they come in, you look at the age, because just like the Spanish people, many of them have the hypertension and diabetes and all that. And then we had the issue with the vitamin D deficiency and all these things. So some of our African American patients also didn't do very well. Now, when it comes to the Caucasian patients, many of them were elderly in their 80s and 70-somethings coming from the nursing homes. So they came in the age and their comorbidities like the COPD. Some of them they were survivors of cancer and all that. So unfortunately, when we got to the critical stage, when we got to what we call the surge, we were making some decisions. Hopefully, we don't have to go back to those decisions anymore. We had limitations in ICU. My hospital, they did very well. Some of the rooms that were huge, then taking just one patient, they went in and divided them up into two rooms, two rooms that could take two patients at a time. They piped them and made sure the ventilation systems were all working well. They had some ventilators, but in the end, we were still short of ventilators. So the tendency to convince people to change their code status to do not resuscitate, was geared up. So we live in America. When somebody is 75, you expect them to have maybe 15 more years to live. But once they caught the COVID and all that, they were encouraged to. It's a difficult topic for me, but some of them were actually encouraged to consider palliative and hospice and all that. And those actually tended to be more of the elderly Caucasians who were coming out from the nursing homes. The younger ones who still got into trouble were the mainly Spanish-speaking people who had diabetes and who had. And then we also had some Native Americans coming in, and their outcomes were also not good. I had a young Native American person coming from the reservation, and the story was that his father had actually just underwent lung transplant and all that. Then this kid, he was in his 30s or something like that, caught the virus and all that. So they had to quickly move him out of the house. They treated him on the reservation, wasn't doing very well. So they brought him to, a tertiary hospital. We did our best, but I kept following him. And unfortunately, after maybe 40 days in the hospital, he died. And many of the people coming from the reservation suffered similar. And I used to work on the reservation until December. So when this hit, I would call back to the reservation to find out what was happening to the people I knew. And the stories I heard were not very comforting. Let me put it that way. Many of them got very sick. Many died and all that. So in terms of the race and age and comorbidities and all that was my experience. Some of them, as I said, I hope we never have to go through that anymore.
Thank you very much, Dr. Usu. We thank you for sharing your experience. Dr. Capilo, we haven't forgotten you. The question, it's your turn now. It seems as if we may have forgotten you, but we definitely were waiting to get to you. On the issue of vaccines, I think it was was it last week or 2 weeks ago, I heard that Russia president's daughter has been injected with the vaccine that Russia has made or created. There's been a lot of things going on right now? People are afraid and concerned. What kind of vaccine is going to be produced? One, when is it going to be produced? And what kind is going to be produced whenever it is produced? And a lot of people are beginning to become anxious because it's as if some of these vaccines are not going through all the 3 stages. Because, for example, the Russia vaccine, I heard that they started the 3rd phase last week when somebody has already taken the vaccine. So the question I want to ask you is, what are your thoughts on the progress made in the area of vaccine development for COVID-19? And what do you have to tell those who have concerns regarding the safety of these vaccines?
Well, I definitely think that the amount of pharmaceutical R&D developed towards the future COVID vaccine is on the equivalent of something like the Manhattan Project. Everybody's mystified by how COVID can completely overwhelm health systems and overwhelm hospital capacity. So some type of progress will need to be made in controlling it, and a vaccine is an integral component of that. However, because it's a profit-based system, it's like a shark feeding frenzy. The first one that can demonstrate a viable vaccine in phase 3 trials could potentially yield oodles and oodles of profits for their shareholders. Because of that, I think that there's going to be a lot of blustering in the coming months. I think with regards to your specific reference to Russia, I think there's a significant amount of skepticism towards whether any of those claims are in fact true. But that doesn't just extend to Russia as well. The Trump administration is making overtures that they might be able to have a deployable vaccine as early as November 1st. And most credible scientific experts in this country consider that to be a ludicrous timeline. I think, as many other speakers have pointed out, the rapidity and speed of reported vaccine development is yet another manifestation of how science has become politicized in this pandemic. We need to wait for an adequate amount of time for a phase 3 rollout, and when it does get rolled out, it also needs to be distributed in an equitable manner. One of the things that we learned during this pandemic is that we all go down if people are not treated equally, we all could potentially go down together. And with regards to vaccine development, if we don't have equitable distribution of vaccine amongst all socioeconomic strata, amongst all geographic strata, we could potentially have a vaccine which is much less effective. Additionally, there was a recent article about COVID vaccine and vaccine research in Africa in the Lancet, where they were saying that this could be an opportunity for African vaccine researchers to be integrally involved in phase 3 development as well. Vaccine research always has a kind of hegemonic disparity between who actually is in control, and this might be an opportunity for both developed and developing countries to have some amount of agency. So with regards to your question in terms of progress made in vaccine development, I think the rapid timelines that have been blusteringly stated by Russia and the United States probably are unrealistic. And that's a significant concern overall for the politicization of science over the next, over the coming cycle of COVID in the coming year.
Thank you very much, Dr. Capilo. We're really grateful for sharing your experience. Dr. Nate, I would hand over to you now.
All right, thank you very much. So the next round of questions go back to Europe. where we started from. Dr. Ahem, any updates with regards to how testing has changed? Are you guys testing asymptomatic patients? Are you just restricting tests to only those who need it? How have you updated your kind of regulations and rules on testing?
Right. So testing has been quite a political subject. At one point, the government had a number to hit, and they did all sorts of somersaults to hit the number. At the moment, in terms of symptoms, the PCR viral test, it's freely available. If you do have symptoms within the first 3 days, there is a number to call, 119. If you call that number, you'll be sent a kit to your house and you'll be able to test. And if, however, you about 4 or 5 days into the symptoms, you either go to a drive-through center and you'll be given a number to go there, where you would then have the test at the site rather than being posted to you. So it is freely available for the viral test. In terms of the antibody testing, it's also available, but that is more restricted. So in terms of health facility workers have been tested first to basically see the antibody levels across board, and then to see who has had it and who hasn't had it, given that with the current situation saying people are losing their immunity status in 3 months, it makes one wonder how useful the antibody status actually is. But antibody testing is also available. It's being used more for research to know where the illnesses are, where the hotspots are. And because at the moment we've moved out of lockdown, we've moved more into where the government says stay alert. And with stay alert, it's about being alert in your environment, seeing where the symptoms are, calculating the R0 value to see where the growth is more. And if the growth is more, then there are local hotspots where testing is more freely available, and then there are local lockdowns. So like an area like Bolton, for instance, in UK, is the hottest area. So then there'll be more testing in that area, and there'll be more localized quarantining, and the social isolation is much, much more. So testing is freely available more for the PCR if you do have symptoms. It's a national line. You just call, you're posted a kit. If you're, however, in about day 4 to day 5 of your symptoms, because if you're past the first 7 days, there's no point. Then you actually go to a drive-through test center. If you need an antibody test, that is more restricted. You still call the call line, but it's more for health workers. Or if you need to find out for any reason you've actually had the COVID in the past, then you'll be given access to it. It is tested more centrally, and it can also be tested from hospital levels, but it's not open to primary care testing at the moment. So that is what I would say about testing in UK.
Yeah, thank you very much, Dr. Ahem. So, Dr. Johnny Yeboah, I think you were mentioning how treatment has changed since we started with the pandemic, azithromycin, with the hydroxychloroquine and all that. Do you feel that Africa has been left out in terms of, for example, when remdesivir came and everybody was pushing towards that? I don't think we had enough to get to Africa. So in terms of treatment regimen changes that has been made, how did you guys adjusted to information that, oh, there is this medication that is really good, but we still don't have access to that?
Okay, so we mainly had to deal with what we had available. So for example, we have azithromycin, we have zinc tablets, we have vitamin C. We are also we also have a past with hydroxychloroquine and then chloroquine. That's in terms of their use in the management of malaria. even with respect to the management of autoimmune diseases like SLE, we use the hydroxychloroquine. So these drugs are not drugs that were strange to us. So it was very easy using them. Yes, along the line, we hear about other drugs, the remdesivir and the others, but these are not drugs that you have available. And this is a pandemic that you are dealing with. So yes, you have you have a drug that you look up to, but you have to also intervene in what you have. So if you look even into our standard treatment guidelines, we made mention of other drugs, and then we also made mention of the fact that it's going to change with respect to current studies. But these are the first line, second line, and third line drugs that we are going to use. So yes, we were aware of the drugs, but we chose to deal with what we had available with us and just work with them.
Okay, just a follow-up question on that. So when the hydroxychloroquine studies came and CDC and all the other big corporations, regulators thought that hydroxychloroquine wasn't a good drug for COVID-19. Did you guys have to change the standard treatment guideline, or because maybe you had a certain experience with that, you still maintained COVID-19, the hydroxychloroquine as a treatment?
See, the hydroxychloroquine finds itself at a point where even amongst scientists and amongst doctors, there's still a debate with respect to that. So that debate was still within the Ghanaian circle. So the debate was ongoing. At the mild and moderate level of COVID-19, the hydroxychloroquine was restricted. But as it gets to the severe and the critical, at that point, then it was used. So we decided to leave the mild and moderate level. We leave the hydroxychloroquine out. But when you get to the critical and the severe state where it's more or less like life and death, at that point, you give minimal relevance to the debate and intervene in the life of the patient. So yes, the debate was here. We were still following the debate, but it was all about intervening in the life of the patient. But at least with the mild and moderate, where we can observe the patient and then look at the vital signs, it's best to leave the hydroxychloroquine out and then monitor the vitals and then work with the cocktail that you were comfortable with. So until the hydroxychloroquine debate is resolved, and then we considered adding them to the mild and the moderate and even the asymptomatic cases in the standard treatment guideline.
Yeah. So again, I think that there's been some interest in this particular topic with hydroxychloroquine, and especially because of all the euphoria it generated. So one of our listeners wanted to ask, I think she's Rosa Pineda, wanted to know if it really worked for you guys in terms of your experience, not like global experience, hydroxychloroquine. In terms of your experience as Ghana managing COVID-19, did you feel like there were, maybe there haven't been a randomized controlled trial or anything like that, but anecdotally, did you feel that there were some positive responses?
It's going to be very difficult for me to say yes to that, because at my level, that's the isolation center, majority of our patients, I would even say over 90% of the patients were not on hydroxychloroquine. They were on the azithromycin, vitamin C, and the zinc, and we never had any issues with it. And we had the recoveries we were looking at. So with respect to that, it would be very difficult for me to say that the absence of hydroxychloroquine made a change. Okay. And then will the presence of hydroxychloroquine make a change? That's also difficult to say. So I will say that the presence or the absence didn't make much difference with respect to where I sit and the patients I managed. That's what I can say with respect to that. But maybe my brother in the upper west can also have something to say about with respect to the critical and the severe patients and whether hydroxychloroquine made much difference with respect to the management of his patients.
Steve, will you want to have a go at it?
Yeah. So actually, what I will also say is that from our asymptomatic and mild cases, none of them was put on hydroxychloroquine, and all of them recovered well without any complications or any other morbidity. So for us, when the case management team even came and visited the consultant, we made them aware clinically, we don't have much evidence to that, even without any kind of treatment, just with the support care, giving them PMOL and all that. They just recovered on their own. So here about those are the ones that we know that. But the mild cases and asymptomatic, but they do well with just the supportive therapy. Thank you.
Thank you so much, Steve. My next question, I'll go to Dr. Capilo. So we've been talking about vaccine. I think you made a very interesting point with regards to the vaccine development thus far. I just wanted us to talk in general about immunity, whether we feel what we know about immunity, getting immunity from the COVID infection itself, and also what these vaccine developers are talking about immunity in terms of what the vaccine can protect us against, if we have any idea.
Well, it's an interesting question. It's a really complicated question. There's a really fantastic review, which is co-authored by Dr. Anthony Fauci, actually, which came out about 3 or 4 days ago in the Journal of Cell Biology, the journal Cell. And some of the implications that him and his co-author made for the future of COVID were somewhat frightening. So they were describing how with the 1918 Spanish flu, for instance, we are still seeing genetic remnants of that flu pandemic years afterwards, with each genetically modified flu strain year after year during each flu season. And they're concerned that COVID could be similar to that in the future, that this could become a seasonal outbreak in the future, and that it could last long beyond its shelf life, even with the initial vaccine. So immunity is a complicated question. Just because this first vaccine works doesn't mean that it's going to portend lifelong immunity, and it doesn't necessarily portend that it could even give you yearly immunity either. So there is no magic bullet with regards to vaccines for COVID. I think that's one of the main lessons from that. And additionally, we have a lot of, in order to get proper herd immunity or group immunity, you have to have the majority of the population buy in to the vaccine. And even now, even though COVID has shut American society down, recent Gallup polls are still saying that something like 30% of Americans wouldn't want to get a COVID vaccine. So that's a major that's a major health beliefs barrier that we're going to come up against. Now, is that going to mean that it'll be impossible to develop society kind of herd immunity to the vaccine? I don't know. There are some scientists who are saying that actually we don't need everybody vaccinated. We just need a substantial number of people in order to, push down the total numbers. But it does pose a substantial challenge to group immunity or herd immunity. So immunity to COVID is going to be it's going to be a discussion that lasts longer than just the spring 2021 deadline that most American politicians want. It's going to be something that I suspect will take a few years of discussion and work on to achieve.
Thank you very much. And I think Dr. Montgomery also pointed in the chat that some people are vaccine hesitant due to the politics and the fear. And I think there is this general vaccine skepticism that is very rife in the United States. I don't know about the European experience, how people are ready for the vaccine being developed. I think Oxford or one of those universities were developing a vaccine.
Yes.
Yeah, I think there's the Oxford trial vaccine going on. It's very well done, I must say. And if it does come out, it would have a lot of people going for it. However, there is always the anti-vaxxers who would always drag at the heel. Currently, with the oncoming flu season, we've actually opened up what we call an expanded program of flu because we're getting ready for the double whammy of coronavirus versus flu season coming together. So if we do have a second wave, so at the moment, all basically BAME people are being encouraged to go for vaccine. If anybody lives with anybody who is in the shielding group, that is those who probably would have some kind of severely vulnerable person. If you live in the same family group, then you're also encouraged to go for vaccination. But in terms of the COVID vaccine itself, we're looking keenly at it. And I am hopeful that there would be a lot of buy into it, and because people are have seen what the illness has done. However, they are the anti-vaxxers, and also we know very well that our people, BAME people, are not very keen on vaccination. Look at the case of the French doctors who said, why don't we go and try these vaccines in Africa? And that caused a lot of uproar. I mean, I think maybe they didn't say it well, but if you look at the whole idea, it's not such a bad thing. Because if you're looking at diseases and looking at vaccines, and we know there are differences, constitutional differences. So the fact that one vaccine works very well in one group, say hypertensive medications, works very well for one group, probably wouldn't work so well for the other group. So we should all go into this vaccine trial business, Africa and Black people generally. That's my feeling anyway. But then when it comes on, I think there will be a good buy-in, and we'll have to encourage our people also to go for it, because we are probably more at risk given the issues that have come up, how we've seen the BME, that's Blacks, Asians, minority ethnic groups being so much more affected. So I'm quite hopeful, but it's not going to come on this year. I don't think it will come this year.
Dr. Blanson, Dr. Yeboah, do you feel Ghanaians are quite receptive with the vaccine idea? Any pause? Then I will let Brother Kelson continue with the questioning.
Yes, you can go ahead.
Okay, so in one breath, I would say it's not very predictable. If you, a case in point is when the Ebola vaccine was going to be tested in one community in Ghana, there was this whole noise about it with respect to why Ghana and all that. So it's not very easy to predict the Ghanaian response with respect to the COVID-19 vaccine. And what is also going to make it quite difficult will be the fact that the Ghanaian community has not really experienced the COVID as it was experienced in Europe and the rest. So they have not seen how deadly the disease can be. So when you come to a community like that to tell them that I want to work on this vaccine, they will tell you that we have more severe diseases as compared to the COVID. So these are hurdles that we will have to cross if we want to work on the vaccine in Ghana. Even with respect to when we're trying to isolate some patients can even tell you that they don't want to isolate because they have not seen a critically ill Ghanaian patient with COVID-19. So that's how bad it is. Someone may decide that he will not wear a face mask because he has not seen a critically ill patient. So based on just these few examples, we are definitely going to meet some hurdles with respect to how the Ghanaian society is going to be receptive to the vaccine. That's notwithstanding, I feel we should always give that a shot because there is an infectious disease, and vaccine is a very good step to take with respect to the management.
All right.
All right, thank you very much. This last discussion ties into the question I'm going to ask Dr. Susan Montgomery. As a public health practitioner, I worry because I think, for me personally, this pandemic has done a lot of harm to public health institutions. So I would want you, being a senior person in public health, just as we are talking about public health is responsible for the education and all that, how much damage has this pandemic caused to public health institutions? In the sense that bringing in the politics, for example, the government of America, the Trump administration decided to stop funding World Health Organization. There's been so much being said about them. So how much damage has it caused to public health institutions?
Well, I want to come back to what I said earlier. There is an answer internationally, by country, and then within the United States. I think internationally, the standing of our premier institution in public health, the CDC, in my mind, has been maybe not irreparable, but strongly affected because it got politicized and they bowed to pressure and basically tried very hard not to contradict a government that released statements that were not science-based. So I think people kind of figured that out. Independent of politics, people are now very weary. I think our public health infrastructure in the United States was already weak and has had years of weakening and not investments. And I think if there is a positive, if there is a change in government, I think people have realized we need to invest in public health. I think that is a positive if there is a positive coming out of that. But that is the big if. If there is a change in leadership where science is acceptable again, I think people have realized, especially by international example, that if you do it differently, it can be quite positive. So I think going forward, we'll have to see. I think in the meantime, reputation of public health is damaged. I feel damaged in my reputation. The training that I had, which kind of then is applicable today, had we followed it and had we not gotten involved in politics and had politics not dictated decision-making, would have actually helped this country through this process and wouldn't have, it resulted in a tremendous economic damage. And to simply say that, oh, well, you know, let's let these minorities, these older folks die by the hundreds of thousands because our economy will go forward, that actually is a very sad statement for a country, but I hear that. And the sad part is that it's not necessary. With respect to the WHO, again, politics. And I think our standing internationally is, for the United States, has been undermined. I have relatives all over Europe. I work in Africa, I work in India. And I can say that where people used to be excited to collaborate with us and respect us and have great respect, I now hear pity. And that's kind of I don't even know what to say, how it feels. You know, my relatives actually feel bad for me. They say, you want to come back? and even my colleagues in Africa, I'm checking in on them, how they're doing, and they're saying, how are you guys doing? I see your statistics. How are you holding up? I think internationally, the damage to public health has been done for the United States. On the other hand, public health has been a successful promoter of successful models. So there is really a case study in how to do it if one does it right, because public health actually does know what to do. And it has shown what not to do if it isn't done right, and if we don't let science drive. This will come into play. I totally agree with Dr. Capilo on this. This will go on for longer times because vaccinations are not going to be a solution. And public health has to become a regular partner to educate people that maybe you need two vaccinations, maybe you need a yearly vaccination, but the science will have to lead us in those answers. But politicians really are not willing to invest in that public health and science model, and they want quick answers because of finances. And those two things are diametrically opposed. I also agree with them that politically speaking, the big learning in COVID has been that we rise together, we fall together. This country's economy has been brought to our knees, tremendously damaged because of the people who got infected and the resulting impact that we actually are still living through. And people are realizing if public health isn't done well, all of us suffer.
Thank you very, very much. Thank you so much. We have a question from one of our audience, and I would like to ask Dr. Capilo, and any other person can also chime in when after Dr. Capilo has tried to address it. The question asks, COVID-19 is an RNA vaccine. I guess COVID-19 is an RNA virus. Classically, RNA vaccines have not been very effective. Any comments?
Well, I don't know. That's up to the FDA and Pfizer and GlaxoSmithKline and all of them to figure that out. But the fact that we're having this conversation, like, well, wait a minute, this is a new proprietary form of vaccine. It historically hasn't been successful in the past, suggests that this is going to take a little bit longer than an election cycle in order for it to get figured out. I mean, most of the, national experts on the subject are thinking, the spring in order to have something that's viable figured out. So it's going to be a while.
Thank you. I don't know if any other person wants to. Okay, Dr. Susan, you can go ahead.
My roots are actually in HIV and AIDS. And when I first started doing HIV and AIDS vaccine research, I truly, in my heart, believed, and Dr. Fauci was one of my heroes with Dr. Hope, that within 5 years, then within 10 years, then within 15 years, we would have a vaccine. Guess what? We do not. So I do believe that there is a solution to this. I am not sure. I agree with Dr. Capilo that this might be not a clear-cut vaccine situation, and it might be a lot more complicated. And again, this is where ideally science should drive the decision-making. Public health and physicians together should do the communication around it, and then we should really work in teamwork.
Thank you. I don't know if Dr. Blanson is still on. Yes. We all heard that the government of Ghana has decided to open the airports, and I think it was open on the 1st of September. I would want you to comment on the systems that the government has put in place to enable a safe opening of the airports.
Okay. All right, thanks. So actually, even before it was announced, I think in his last but one address, he made us aware that with the reopening of the airport, they are going to consult the aviation industry as well as the health, sector. So every decision is like that the government takes. It has to do with like consulting all the various, stakeholders. So after the consultation has been done with our pattern of infection and all that, the fact that active cases are going down, the number of new cases that we have a day is also going down and all that. Then with the easing restrictions that have started about 3 months ago, this one also came in. So now the measures that have been put in place are, one, before the person even comes, he has to get a negative PCR test for COVID-19, and this should be done in less than 72 hours. So less than 3 days, you have a test done. And right when you disembark from the aircraft, you have to put on a face mask. And when you get there, they will screen you. You go through the screen, and as part of the screening, they will also do a rapid diagnostic test. And those who are go and do whatever you came here to test results takes about up to 15 minutes, maximum 30 minutes. So if your result also comes out positive, there is a case management team over there that they counsel you, they take you through, and then you are taken to where they have to manage you. So these are some of the measures that have been put in place to ensure that at least as we are easing the restrictions, we don't end up compounding whatever situation that we have on the ground. Yeah.
Thank you very much. Dr. Nate.
All right. Yeah. So, Dr. Jumo, we wanted to tap in your experience with this question. We know you really love missions, and you've been going to Africa, and with your work as an ED physician and kind of your exposure to the health system in Africa, we wanted to ask if there are any lessons that you have acquired here, any mistakes that they can learn from and better improve the management of COVID-19. I don't know if this is really a legitimate question, since Ghana has done much better in terms of managing these cases than the United States. But just in general, what are some of your thoughts?
Well, thanks again. But overall, I think Ghana has done well. I've been on multiple educational platforms, and I've heard from a lot of top leaders in the Ghana medical field, and I think they have done well. Like in of course, when I was born and bred in Ghana, I did my undergraduate and my secondary school there. So I know a little bit about the health system in Ghana. And I've been there, I think, 4 different times on different medical trips. And it's been interesting. By nature, Ghanaians are very resilient, and I would like to bring our nutrition into it, their nutrition, I think lately that has been changing, but ideally, their nutrition, the little that they have and what they have eaten has really, boosted their immune system. They are resistant to certain diseases. Because my previous business, you go there and you see somebody, they tell you their age, and you'd be surprised. I'm like, are you really 80? And you're walking straight, and like the only thing you're taking is this medicine of blood pressure. So they've done well in terms of their food choices and everything else. Yes, it's true that the healthcare system is sometimes pay for service, so people usually delay their care, or usually, like Dr. Montgomery was saying, Ghanaians don't like to talk about their disease process. So, they stay home until it's too late, or they hear about this free medical, services that they come along, and then you have to deal with them. And some of them, their main issue is like, we don't have money. So that's the issue. So I'm glad the national health system is being revamped, and at least, for primary care, people will have access to some initial, management until they can improve their health status. But I think overall the nutrition has been very, very, very great, if you ask me. The Kwaususwa, the Kotomre, and the Nkrumahs, they've all done well. to the extent that, as you know, I already have a Kwausu soy in my backyard, thanks to my wife. So, and I didn't know until today that the leaves are also edible. So, kudos to Ghanaians and kudos to Ghanaian farmers. Thank you.
All right,
thank you very
much. I think this is time for our audience, people who have joined us on Facebook, on YouTube, on the various channels, and on Zoom. If you have any questions, please, this is the time you're free to post your questions or ask your questions. If you don't want to ask by showing up, you can actually type it in the chat box and we'll read out on your behalf. So the floor is open for any questions or contributions.
I think Dr. Susan Montgomery has a question concerning testing. She says testing is critical, but sadly in the US, we still do not have enough tests, like quick testing, 15 minutes testing. Ironically, there is more testing in other countries. The question is how is testing in Africa? Are we having much more faster turnaround for results? And how has this really helped with the COVID management? So Dr. Blanson or Dr. Jenny Yeboah can help with this question.
Okay. All right. Thank you. What I would say is that, yes, we have seen some improvement in our testing. And as I said, my colleague said, with the updated discharge protocol from the WHO that Ghana adopted, what it meant was that instead of having a minimum of 3 tests for a patient before he's declared as recovered or discharged clinically, now just with 1 test, we're able to do that, because if you are asymptomatic, now our protocol is that after 14 days, clinically, you are cleared and we de-isolate. The recovery process itself will take many, days, but it's been proven that you are not going to be infected. Then if you have the mild case, you are mild, that one too, after you have become asymptomatic for like 3 days, then that one too, that's there. So that's enabled us to now test more people, because what it means that you don't spend so much resources on 1 patient. Then the other thing too has to do with the sample pooling that was done initially. So in that case, what it means that a lot of tests or samples could be tested at a go, and that one really helped. We still are not completely, there yet. There are still some isolated areas where we have some few challenges with the test result, especially where I work. But as I rightly said, my region is the poorest in the whole country. So that is not, cannot be the true picture of what's going on in the entire country. Now, usually within 48 hours, a lot of people, even in the district, are getting their tests. So, that's basically what we did.
All right, thank you. I see that Dr. Owusu Osei Tutu's hand is up. Uncle, please, you can ask your question. Uncle, your mic is on mute, so we can't hear you. Okay, whilst Dr. Osei Tutu is preparing for his question, I have a question here. Those who are in Phoenix, do you believe that it is now a good time to reopen schools and churches based on the numbers given? Those of you in Phoenix, what's your opinion regarding reopening of schools and churches?
Well, looking at the numbers that the government is putting out, it would make sense to start talking about that. But we also know that testing has gone down a lot. We are not testing as much anymore because people were discouraged. They make a long queue in the heat, the heat here. And then it takes so long, sometimes a week, to get the results back. So they stop testing. So the numbers that they coming out with, that it's difficult to know if they are the real thing or people are just decided not to go for the testing and all that. But the testing part is, is just one component. We all know that I've been surprised, through this pandemic. We all know that prevention, they say, is better than cure. This is about the only time when people are talking about therapeutics instead of talking about prevention, the complicated, expensive therapeutics, rather than prevention with a mask and all that. So there are still pockets here in Phoenix area that they are resistant to wearing the mask. And the schools, if you look at the schools in Europe where they have reopened and all that, they have all these plexiglasses and they have all these things that separate kids from each other. They are not doing that here. All they're saying is that look at the numbers and go back to school. It's very hot here in summer, and when the kids go to school, they're going to stay indoors. They're not going to be able to stay outdoors because of the heat and all that. So there's a very high chance that people, once they start going to school, we're going to see the kids, at least, and we have said kids don't get very sick and all that, but a few that get very sick, they're really very sick. So we have to be careful. Then when it comes to the churches, I know some churches have reopened. Some of them had to close again because some members started catching the disease. And I don't, I've even heard that the Ghanaian community here, some of the churches that open, some of their members have caught the virus. So we have to be very careful. For my church and, similar churches that I know about, especially the churches that are attended by the African community, Blacks and African Americans, many of them are making the decision not to go back to church until maybe January or sometime like that, because we all know when the disease enters those churches with the African Americans and all that, the effects are very devastating. So that's where we are now. We don't know whether to believe what the government is saying, because when they announced kids should go back to school, they said they were asking the GDP, how much that could, bring up the GDP. So if you saying this, and we know part of your reasoning is because of the economic issues and all that, that's a difficult pill to swallow. So that's my take on it.
Thank you very much. Dr. Mangure.
Yeah, I couldn't agree more with my colleague. Again, I want to come back because I want to leave our readers with some clear messages. We have science and we have science-informed approaches. The terrible thing about COVID is, yes, some people die of it on the far end, and some people get sick of it, and it's not pleasant. And we still don't know the long-term consequences, by the way. We haven't even talked about that. But there are others who get infected, and the insidious of this disease is that there are so many others that deal with it relatively positively, but they become little super spreaders to those who are at risk. So when we talk about opening schools and opening churches, people who have subclinical presentation of COVID are dangerous to those who are not, unless we do what we know from science that works: keep distance, wear masks, test, socially isolate those that are infected, and protect the population at large. Do a lot of hand washing, etc., etc. So we know what to do, and I really want to say that COVID doesn't have to shut down a country if it's handled well. It's a tough disease, especially with the many, many people that are infected that potentially could affect those who are at higher risk. But we do have models that we know how to handle it. If we only had a combined discussion like the one you have today, where physicians and scientists and public health stand together and share information that's clear, then we could go back to actually having an economy that works, go back to having healthcare, and address some of the health care that is needed for the many that who are right now not even seeking healthcare. So I don't want to leave us hopeless. I don't think the vaccination is going to be it, but there are things we can do. And again, they are science-based. And if we stand together, we can actually do that.
Thank you so much. There's another question here that I want to ask Dr. Anthony Janim Yeboah. The question says, what are the benefits of Sobolo with regards to COVID-19? That is the hibiscus leaf.
Yes, it has found its way into the COVID discourse in the Ghanaian society, where a number of people are of the view that the Sobolo drink has some therapeutic effect with respect to the management of COVID. So, in fact, I've come across a number of patients who actually come to the isolation center with gallons of Sobolo just to come and also take alongside the management that we are giving to them. But I believe the Sobolo question is part of a number of unanswered questions with respect to how we have had a level of success story in Ghana, because I can't say that Sobolo has a therapeutic effect. Neither can I say that it does not. That notwithstanding, there are some other questions like, is it possible that we have a level of, does it affect the gut microbiota that is also having a level of influence in our immune system to help how our bodies manage the COVID-19? That's a question to answer. Issues about already existing antibodies towards the virus in the Ghanaian setting. These are questions that we have to answer. There was this two different research that were, one was published, I think, just this year. Another one was in 2014 that were looking at human coronavirus in the Ghanaian setting. And they found that the other 4 members in the human coronavirus who cause a mild upper respiratory tract infection, we have some in the Ghanaian community. There was one that was in a rural Ghanaian community. They even sequenced the virus and they realized that they are just similar to the human coronavirus that we have in the global setting. And the thing is that if other bigger countries have that same strain, why are they dying? Why don't they have that antibody? So that also doesn't answer the question. So there are a number of unanswered questions with respect to COVID-19 in Ghana, the success stories and all that. So I think the future of COVID-19 research in Ghana must look at Sobolo and other questions. So for now, Sobolo is a drink that we always drink. So you can just continue just having your parties with the Sobolo drink. And you can just entertain the thought of the therapeutic effect, but you just need a concrete scientific answer with respect to that. Yeah.
Thank you very much.
Thanks so much. Yeah, we are about rounding off on our discussions. I think I just want to ask Dr. Capilo one question. When you were talking, you talked about how you had to balance educating people about their fears with COVID and all that in the initial stages. How has this education of the public in terms of or your patients in terms of their fears, their anxieties, how have you succeeded in getting them to have a much more rounded and balanced view about COVID?
Yeah, so good question. So when people come in to the hospital and they're acutely hypoxic and they're on 4 liters and they feel terrible, their level of understanding of COVID is pretty much whatever the mainstream news has told them. And in in a condition where even scientists are at odds and divergent as to what can happen with the disease, it's even more confusing for the general public to sort through it. So what I do, number one, is I actually start first by reassuring them. A lot of people who came in, especially in the first few months, thought it was like a death sentence when they came in, and I had to explain to them, look, this is a respiratory disease that could potentially have some very deleterious side effects, but we can do a lot for it. We can do a lot that's very simple for it. So my first step would be to reassure them and to try to make them feel better, because a lot of people are very, very scared. The second thing to do, however, is to explain, that in a significant minority of patients, very significant things can happen, and those aren't just the respiratory system. Pulmonary emboli can occur, CVAs can occur. One can go into shock or cytokine release from the robust inflammatory response in the body. So I would try to have equal measures of both hope and fear that I would kind of inspire in people about it. And I find that kind of balanced and reasoned approach would make people feel better in general. The other question is, how do you deal with like denialists or anti-maskers or individuals who reject allopathic models of understanding for disease? And I find with other anti-vaxxers and other places, like I see a lot of parents who are anti-vaxxers because I have a pediatric clinic. What I first do is, and this sounds simple, but I'll explain what I mean by I acknowledge their concerns. By which I mean, like, I'll acknowledge with them, look, there are many issues in allopathic medicine that there is an amount of scamming and grifting in. There are many types of experimental chemotherapeutics and immunomodulatory agents that have tremendous risks. But then I try to explain to them, like, even though I also share your skepticism, vaccines are not one of them. Treatments such as dexamethasone in the hospital for COVID can provide a substantial mortality benefit. And if you're dealing with somebody who has a lot of vaccine hesitancy, medication hesitancy, denialism in any domain, acknowledging their concern, acknowledging their skepticism, agreeing with that skepticism, but explaining why it's not really a good idea in their specific situation, that tends to help them feel like they're being heard. Especially with somebody who harbors different views than you about medical issues, you want to at least acknowledge them that their views are being heard. And if they can, it's much more likely that they'll be more interested in treatment if they feel like they're being listened to rather than being dictated to.
Yeah, thank you so much. Just a quick one, still, Dr. Capilo, following up on some of these denial and all that. There is a question in the chat concerning 5G and COVID. Just a brief comment about it. I think people bought into the conspiracy theory about 5G and COVID. Someone wanted an answer.
Right. So 5G is a new form of internet and Wi-Fi that is high speed, that's prevalent in many areas of Europe and Canada, and they're trying to ramp up development of it in America. There's no demonstrated association and no evidence at all linking any type of electromagnetic waves to a predisposition to COVID. There are significant health concerns about 5G. It has nothing to do with COVID, but they are legitimate and they are real, and they should be considered by experts. But there is no data whatsoever that suggests an association between 5G as well as COVID.
Thank you so much. That was brief and well answered. So just to recap all that we've discussed today, we had our team COVID-19 through an international lens, lessons for now and beyond. And as part of our panelists, we have Dr. Susan Montgomery, who is a professor of health promotion and education at Loma Linda University. I would like you to give us your parting words, like lessons that we can pick from now, and that will help us in the future.
Well, I think I went there, but let me summarize. I think that COVID is a concerning disease, especially in the United States and in some European countries. It has wreaked havoc on personal lives and on economies. I do believe that a science-based approach where public health collaborates with physicians, acknowledges the limitations of what we know and what we are learning because this is new, and actually informs the public in a trustworthy fashion that is dictated and fully acknowledges that there are clear established ways we can prevent rather than to get sick, and that we've learned a lot about how to treat. We've heard a lot of physicians talk about the treatment, how it developed. We've learned a whole lot. From where it first started to now, we actually have been on an amazing speed in our response. So we know how to prevent relatively well. We know how to deal with a pandemic, and we know how to treat. So we have a lot of solutions, but we have to acknowledge that it is significant and that it's insidious in that it affects many more that then spread it to others. And if we care about our environment, if we care about those in our society that are less advantaged, we all have to chip in because in the end, everybody will gain.
Thank you so much. So, Dr. Anthony Jenny Yeboah, with your colleagues in Ghana, I think you've done a yeoman's job bringing down the numbers and making sure that our people back home are safe. We just want some parting words from you, lessons you've learned up to this far, and what we can take into the future.
Okay, so thank you very much. I think COVID-19 is reminding us that we need to use a science-based approach to manage our problems. And then if look at the Ghanaian society, a very religious society with a number of myths and superstitions and others, if there's anything that COVID can tell us, is that we need to give relevance to science to answer our problems. We are alive today because we gave an ear to science. So I think we need to look at that. And then the next thing is that we must not enjoy the lack of answers with respect to some of our success stories. We need to find answers to them so that in the next 10 years, if there's another pandemic, we should not manage it as we managed it now. We need to find answers. We need to know why the death rate in Ghana is that low. We need to know why some people never got and some people get a milder form. We need to know why some people got a very severe form. We need to find those answers. There's one interesting pair of patients that I saw. That was a father who was a middle-aged man and the daughter who was less than a year. The daughter was the one who got a COVID-19, so we had to isolate the daughter. But the father had to come with the daughter to the isolation center. They were with us for about more than 4 weeks, to about 5 weeks. The father never tested positive for the COVID-19. The daughter, how possible that this man came into an isolation center with the daughter and never tested positive for the virus. He was tested like 3 times and none of them tested positive. So there are a number of questions that we need to answer. So COVID is telling us to look for answers, and that is what I can say for now.
Thank you so much, Dr. Jenny Yeboah. Dr. Ahem, with your European experience, how you guys went through people dying in the thousands to now opening up your European leagues and sports and activities, thinking about the future. we just want to know which lessons you've picked up and the way forward.
Right, thank you very much. It's a great opportunity to share and learn all over the world what's happening in US, in Ghana. How I would sum it up is this way, that COVID-19 basically is now with us and probably is going to be with us for some time in the foreseeable future. So we would have to deal with it and learn to go on with our lives. Lockdown has been eased. In the UK, people are back in schools, and children are back in schools, and primary, secondary school, and universities are working their ways about how to go back to schools. It gave the world an opportunity to reset. We were always on the move. Flights were going all over the world, and people were just on the go. COVID-19 is giving us an opportunity to rethink about our environment. I don't think we're going to do things the same way we used to. And there's going to be a lot of digitization in the healthcare delivery. Now we're doing a lot of teleconsults, and I think going forward, things that would have taken years to go through the bureaucracy and the governance and everything has been fast forwarded, and that is also going to go on. Simple measures like hand washing and a bit of social distancing and testing is going to help. But overall, what I've learned at the end of this COVID-19 is that lifestyle medicine is probably the key factor, because most people, 99% of those who have died in Europe, had a comorbid illness. So if you have a comorbid illness and you control it, then that is the best way you're going to control yourself in terms of COVID-19. So it's about returning to the basic lifestyle measures that would keep us safe in these times. Thank you.
Thank you so much, Dr. Osudome. You are next to tell us your parting words. There is a question on steam inhalation and if it's beneficial in terms of COVID. Just a brief word on that, and then you can give us your parting message.
And just to add to that, there's another question asking how if mask was also wearing of mask was effective in Ghana.
Let me talk about what I know quickly, then the others will. Yeah, so from my part of the world, and everybody, we were at the top of the chart, so many. Arizona, we have maybe about 5 million people. But if you look at the number of infections we were getting per day and the number of people who were dying, then if you calculated the per capita infection and death, we were very high out there. The governor initially was actually prohibiting the municipalities from, enacting mask orders and all that. Eventually he had to give in and then allowed them to. And even that, he said, I'm not going to make it statewide. Every community should make their own decision. And they put on the mask, and lo and behold, I mean, he did his part by closing the nightclubs and all those things. But lo and behold, within 4 weeks, our numbers just came down. So what we know is the mask works. You go to the hospital, the offices and all that, with all these people, nurses and patients coming in. The only defense we have is a little. You can't even practice the social distancing very much there. But everybody is wearing the mask, and because of that, it's prevented a lot of people from getting the COVID. I believe the same is true in Ghana and everywhere. Ghana is difficult to do all this social distancing on the trot floor or in the buses or even in some homes. But at least even if the mask alone is not going to be 100% effective, even if it cuts down by 30-40%, that's a lot of lives saved. So I think we should encourage Ghanaians to go ahead and continue wearing their masks. And for those of us here, we are hearing that the South Americans didn't get the flu. This year, Australians and South Americans, there was not much of a flu this year because they wearing the mask and they're doing the hand washing and the social distancing. So it also helps with a lot of the other respiratory tracts, even pneumonias and all that. I'm sure if you take out the COVID pneumonias and all that, go back to Ghana to check and take out the COVID pneumonias, the regular community-acquired pneumonias, they probably went down because people are wearing masks and washing their hands and all that. Now, when it comes to the steam inhalation, that's a difficult. I mean, my wife forces me to do it. I don't know if it works or not. It's probably like the chloroquine, except that in this case, it's not harmful. We know that chloroquine can be harmful. So if there's anything, if the inhalation is going to make the mucous membranes healthier, and you know, when the viruses and bacteria and all that, when they come, when they get into the system, they're looking for damaged, you know, mucosa and things like that to invade. So if the steam and all that would help us to maintain good, you know, mucosa, maybe we improve one level of defense. So that could be it. And especially if it's not hurting, like the Sobolo, if it doesn't hurt you, I'll go ahead and use it.
Thank you so much, Dr. Osudome. Dr. Matthew Capilo, your parting words.
Thank you very much for allowing me to participate in this conversation. I'm really interested to see how we can learn from COVID to help deal with what are expected to be future pandemics over the coming decades around the world. I thank you to Kwame again for inviting me. For those of you who don't know, I formerly worked as Kwame's MCAT test prep instructor about 8 to 10 years ago, and then lo and behold, years later, he's a resident at my university. So thank you again, Kwame.
Thank you so much, Dr. Capello. Yeah, thanks. Thanks for coming by. Dr. Jumo, emergency physician, your role and the lessons you've picked up and what you think going forward we should focus on.
All right, thank you for considering me as a panelist in this nice webinar that we had. My parting words is, yes, COVID-19 is a concerning disease. Yes, COVID-19 is a real disease, R-E-A-L, real disease. And yes, COVID-19 is no respecter of persons. And yes, there are more questions than answers. But if we adhere to the simple things to prevent this disease, I think we'll do well. So as healthcare professionals, we should do our best to focus more on the prevention and let the scientists and the pharmaceutical companies worry about finding the vaccines, because there's more we can do as a group and educate ourselves about prevention, the wearing of masks, social distances, and the little things like that. So let's focus on the prevention. And with the flu season around the corner, like Dr. Osudome was saying, if we can keep our masks and everything, we can kill about 4 birds with 1 stone. Just a simple mask can take out the, you know, reduction of the regular influenza A and B, COVID-19, and probably, you know, complication from the virus to getting like secondary pneumonia and all that stuff. So let's talk about prevention, 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 prevention. And let's keep it simple, KIS. Thank you.
Thank you so much. Thank you so much, Dr. Jumo. And just to add on to that, that means that we should be getting our flu shots as early as possible as part of our prevention campaign. Every one of us, especially those of us who have flu shots as our regular annual preventive vaccine, let's get them as early as possible and continue to protect ourselves. So we will go on to Dr. Blanson, your parting words for us as you continue to help Ghana through COVID-19.
All right. So what this pandemic has taught us is that we have to work together as a country. We have to continue to do the simple thing. The unity is important because during this pandemic, the support was coming from everywhere. Even the opposition party Although we are in a very, the political season is very charged, but in terms of COVID, everybody was trying to help, and that has really helped a lot. The other one too that I want to say is that this pandemic has taught us that there are certain simple things that we can do for ourselves as a nation. Had it not been for COVID, certain things like hand sanitizers, the face mask, face shields, and all that, we still continue to depend on external supply. So that stressful situation has made us know that as a people, there are certain things that we can actually do for ourselves. And I think going forward, these are some of the things that we should continue to do. Thanks.
Thank you so much, Dr. Blanson. And I think someone wanted to know the extent to which masks helped in Ghana. I don't know whether you want to make just a brief comment on that, and then I think we can round it.
All right. So, we don't have any current maybe study or whatever, but what I've noticed is that the mask wearing, when we enforce the mask wearing, at least even for those that were confirmed cases, when we trace their contacts, most of them were not having it. So I think that the mask wearing, it's important. And even as we started easing restrictions, the number of cases that we are recording maybe in the churches and the schools and all that, comparatively, is not that alarming. So I think the mask wearing together with the other preventive measures, really help. Yeah.
Thank you so much for this successful discussions. Thank you all our panelists for your time spent. I think you've done a lot for humanity, and you continue to do this. And thank you for the education you've provided today. I will let our the USTA team take over from here and then round up everything.
Okay, thank you very much, Dr. Nate and Brother Kerson for leading this program. On behalf of USTA, thank you. We also want to appreciate all the panelists, Dr. Montgomery, Dr. Capilo, Dr. Blanson, Dr. Jamie Yeboah, Dr. Jamal, Dr. Ahem, and I think I got everybody. Thank you all for accepting this invitation. And then also we want to thank the audience. Those that are able to join through Zoom. I know some are watching on Obra TV, some are watching on Taibo channel. I think some are also listening on Donkudo Radio and Redeemer Radio in the UK. We thank you all for listening. We hope that whatever discussion we had here today is going to be lessons for now and then for the future. One thing that we just want to impress on Ghanaians is because of the COVID, this year our mission work won't be like the way we did it in Ghana. We are still working on getting over 2020 capsular surgeries done. See people for eye care and other the screening of diabetes and hypertension. But this time, we want to make sure that we are safe. The volunteers and all those that are coming for help are also safe. So we're going to do it in a social distant manner. So what we're going to do is, instead of doing like 5 days, we are planning to do it for a longer time, between 3 to 4 months. If you need capsular surgery, tell our people to go to Asamai to get registered, go to Namon SD Hospital to get registered, go to Sunyai SD Hospital to get registered. If you are in Accra, Central Region site, you can go to Dr. Boatin Wiafi's place at Kaswa. For next year, we are planning to go next year. We already know our date. That's May 10 to May 14, 2021. We hope at that time, this COVID thing, we got in the vaccine, everything is safe for travel. If you want to join or you want to know more, if you want to help us, help us, you want to help, use that to help Africa, just visit us on our website, www.unitedservicetoafrica.org. Once again, thank you and God bless you all. I'll invite Pastor Seth Prekon. He's the board chairman of board secretary to the board of United Service to Africa, I will invite him to lead us in a word of prayer. Thank you very much.
Thank you, Dr. Ahem. Before I pray, I want to emphasize one thing that COVID-19 has caused in terms of spiritual care as well. Here at Loma Linda, during the pandemic, there was an anxiety of how many chaplains will remain in service because of the limited service that we were having. But President made us know that no chaplain a week. We have 72 hours where we stay at the office and visit patients during the day, during the night, and to provide spiritual care for patients, their families, and the nurses and the doctors in this traumatic way. It's very important to see how spiritual care is also impacting the work of COVID-19 era. Let us have a word of prayer. Our Father in heaven, we thank you so much for this fruitful discussion. We thank you for the knowledge that we have shared across the world and the globe. We pray that you will bless these doctors and all the nurses and all the other healthcare professionals in the front line who are daily sacrificing their lives and making sure patients who come and sometimes will not have their family over there with them, with the fear of death. Lord, we're praying that you will be with them, and as they may not even have chaplains to be at their healthcare places to provide spiritual care needed for those people who are passing. But you will be with them, and as they offer prayer for those people, I believe that you will provide comfort for the families that are losing their loved ones as well. We're praying for their protection and their guidance. The issue of going to care for COVID patients and going home to see your family as well has done a lot of anxiety on all the workers. And we pray that, Lord, as they put themselves out there, you also take care of them so that when they go home, they will be able to safely go home and be with their families. Bless us this time as we continue to be with you. In Jesus' name we pray. Amen.
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 Thank you all.
Thank you.
Bye-bye.